All right, so we're going to get started soon. For those who are joining us online, I do have a QR code on the screen here if you want to participate in my quizzes. And you can see how well you do. Some of it's knowledge-based, some of it is going to be luck-based. And then also, if you want to let everyone know that you're here, this is the other QR code. I think this one matters just a little bit more than the other one. I don't have Dr. Rangrass being the MC today, so I get to hype myself up. My name is Rob. I'm one of the CA3s giving my CA3 lecture. Honestly, I don't have much titles beyond that. For special awards I've received, I got the class clown superlative in med school. And before med school, 1 month I was the highest bowler of the night, 10 out of the 30 days. And you get like a little reward to like come back to bowl. And I was just on a hot streak. And so my name was up on the wall 10 times. I felt very special then. Thank you. All right. Okay, so disclosures, no money has been involved in this presentation. So today's lecture is the ERAS tour, Rob's version, by me, CA3, no further titles behind my name. Once again, I gave a lecture last year that I didn't have money. I still don't, and I probably won't for another 10 months. All right, so here's the learning objectives, and kind of what we're going to do is kind of talk about how ERAS was made and discuss the different phases of perioperative care for which ERAS can be involved in. Keep in mind that when I was reviewing this, there was a lot more to it than what we're going over, but I focused on the things that us as anesthesiologists can be involved in to further improve ERAS. So let's start with the beginning, the early Taylor Swift albums, except for the 1989, because that was just the year she was born, so I thought it was appropriate. All right, so quiz time. The first ERAS protocol was made with which surgical specialty in mind? We got some quick ones already. All right, so it looks like the heavy favorite is colorectal. Congratulations, that is correct. So ERAS originally started as under the name of fast track surgery by Dr. Kenrick Ellick, a Danish surgeon, whose primary specialty was the pathophysiology of surgery and its stress on the human body. There's this quote that he's perhaps the most well-known surgeon amongst anesthesiologists around the world, and he was told this when he was receiving an anesthesiology research and excellence award back in 2014. And Dr. Kellick was quoted as, well, no single technique or drug regimen has been shown to eliminate post-operative morbidity and mortality. Multimodal interventions may lead to a major reduction in undesirable sequelae with improved recovery. This quote actually led back to when he was first creating it. He was able to observe that patients with similar comorbidities undergoing the same surgery were still having a huge variation in outcomes. And so his goal was to see if he can eliminate those variations. And so that's where he created the fast track surgery protocol when he involved multiple specialties from anesthesiology to pre-op and post-op nursing staff. And so he created this article about the different phases of care and that the effects it can have on the body, including malnutrition, alcohol abuse, the actual surgical stress, temperature management, pain response, post-operative care, being able to get early mobilization, early feeding. So once he created that in 2001, there was an ERAS study group that was created saying that there was a great discrepancy between actual practice and what was already known to be best practice. And so they wanted to be able to institute a plan to better get these best practices involved. In 2005, ERAS developed its first protocol, but it wasn't being integrated too well. And so then they formed their own society and started implementing their protocol starting in Sweden. And what I have in bold here is their mission statement: to develop perioperative care and to improve recovery through research, education, audit, and implementation of evidence-based practice. Ever since then, it's taken off, and now it's a very sexy subject in the perioperative care world and started expanding across a lot of specialties. And for those who want to dive further into learning and education, you can actually go to erassociety.org, and for free, since I have no money, you can see all the separate specialties that they have. And there's some very specific stuff on there, and they actually do have one specifically for anesthesiology as well. So when they started their implementation in Sweden, they started a meta-analysis review to see, does this work? And they actually based this on the fact that there's really not a single aspect of ERAS that led to these improved outcomes. But the big emphasis was that you have to implement multiple elements of the ERAS protocol. And you'll actually find out as we go throughout this lecture, a lot of studies show no difference in outcomes, no difference in length of hospital stay when these ERAS elements are isolated as controls. But when they have these multiple elements come into hand, that's where you'll see the improved outcomes. So with this one that involved 4 elements of the ERAS protocol, length of stay was found to be 2.5 days shorter. Post-hour complication rate was reduced by 50%, which they didn't specifically define in their articles too well, and no significance on readmission and mortality. In 2020, another meta-analysis was performed, and they saw that cost reduction was about $640, which is good for those of us who don't have money. Morbidity reduction had a relative risk reduction of 0.62, and time to first flatus also significantly decreased. So quick overview of current ERAS guidelines, which was given via the healthcare.com. And then we're going to dive a little bit deeper on the parts that us as anesthesiologists can help abide by. Okay, quiz time. And for those who ask if I'm a Swiftie, I am now after making this presentation. All right, looks like we do have a couple Swifties out there as well. Speak now is the correct answer. So, speak now, talking with our patients. There's actually a specific portion in the ERAS guidelines that talks about perioperative education, the impact it has on the patient. It can facilitate postoperative recovery and pain relief, particularly in patients who exhibit mostly denial and highest levels of anxiety. What I thought was interesting was there was no difference between a formal booklet or pamphlet versus an informal sit-down conversation. As long as the education occurred, that's all that really mattered. When patients did receive education, there was a reduction in readmission rates when ERAS was standardized. And this is actually likely due to patient confidence at home with stoma management and so forth. So luckily, the nurse practitioners were kind enough to give me what we give the patients in the PAT clinic. And it actually gives a full rundown of what to expect pre-op, intra-op, and post-op. explains what ERAS is, explains what surgical stress can have on the body, and also specific steps for them that they should take. For example, what to take days before surgery, day of surgery, which medications, and so forth. This one talks about the post-operative course as well, leaving the hospital, what will go on, what to expect for pain management, and then also how to better common complications and what you can do to handle it at home. These were just a couple of the pages, and overall, I believe it's about a 12-page booklet. So why does it matter to us? I feel like when I talk to patients in pre-op, you can see that there can be a lot of misunderstanding. Many patients sometimes expect them to be absolutely pain-free, and it's explaining to them that the goal is actually to make the pain manageable, not absolutely pain-free. How many of our patients getting anxious when they find out that they will be intubated for the procedure? And I've actually had a couple patients ask, am I going to be asleep for that? And in my head, it's like, well, yeah, but from their end, they don't know. And so for us, it's the managing expectations and being able to explain clearly and offer them opportunities to ask us questions. I used to be a waiter at Texas Roadhouse, and one thing I learned with customers is the managing expectations, where some would expect food out to come sooner, but if you explain to them, hey, we're running a little bit behind, who's going to come out a little later, the expectation was managed, and it actually led to overall more satisfaction with the customer's care, which I think this can translate over into the patient in a hospital setting with managing those expectations. All right, midnight, MPO status. I know, clever. All right, true false. ERAS guidelines recommend most patients be MPO after midnight. I don't know if like one person hit false or everyone's hitting false. We'll go with the latter. Yeah, correct. It's false. The midnight status doesn't matter. It's actually strictly just the hours before the surgery. And what I found interesting with this is I feel like as an institution at St. Louis University, we can actually do a little bit better with this, because we say remain MPO after midnight as a basic standard, and that's true for first start cases, but we need to keep in mind that not every patient is a first start case. So just a quick reminder, fried fatty foods, 8 hours or more, light meals, 6 hours, clear liquids, 2 hours. So the reason I mention this is we've all had patients that are going an elective case at 3 p.m. and that they're under the impression that they need to be strict MPO at midnight. The ESPEN guidelines suggest there's great evidence to avoid MPO after midnight guidelines for most patients. And also that's beneficial to encourage PO carbohydrate loading in most patients 2 hours prior to surgery, as long as it's appropriate for the patient. And this is specifically for patients without pulmonary aspiration risks. When I just came off the ICU rotation last month, and I remember there was one patient that had a 6 p.m. elective case the next day. And in the note, it said MPO after midnight by the surgery team. And in my head, it was like, okay, that's not true. And so I called the nurse. I was like, hey, they can have clear liquids up until, we'll say, 3 p.m. The patient was very grateful for that, by the way. So what does the ERAS protocol say about this? Consuming clear liquids 2 to 4 hours prior to surgery compared to greater than 4 hours showed no difference in gastric volume and gastric pH values. But patients reported less hunger, less thirst when consuming it 2 to 4 hours prior to surgery. Specifically in point number 4, it's a little bit contradictory to point 1, but when clear liquids were given 2 to 4 hours prior to surgery, patients were reported to be a lower risk of aspiration as they had less gastric volume and a higher pH. The biggest emphasis here, though, is that there was no superiority and no harm between the two studies. And these volumes range from 100 cc's or 2 cc's per kilogram in children to unrestricted amounts in adults. However, for full safety measure, currently about 400 cc's is recommended preoperatively. And so why do we want to encourage this? Because we want to avoid prolonged fasting. So the short-term fasting we can't avoid, unfortunately, with surgery. But the glucose starts going to be created through glycogenolysis, and the body's energy expenditure will decrease by about 5 to 10%. Long-term wise, your body will then convert these glucose stores and start depleting it in the liver, which will occur around the 18 to 24-hour mark. Protein loss will start occurring, and then you'll have increased insulin resistance. And then once the 24-hour mark hits, gluconeogenesis will start occurring from amino acids, glycerol, and lactate. After being fed, the body switches from a catabolic state to an anabolic state, which lasts around 4 hours, which is the goal of carbohydrate loading per the colorectal guidelines. So there's a common misconception that we do it to stimulate gut motility, but there hasn't been any studies on the colorectal and about that actually being effective. The biggest emphasis is that your body goes from a catabolic state to an anabolic state. And so via these charts here, it's just the difference between the impact of surgery and prolonged fasting and how it can lead to the insulin resistance. So you release endogenous catecholamines that affect the liver. Fasting, you'll release glucagon, and then also surgical stress, you'll get inflammatory mediators and cytokine release that will also lead to the insulin resistance. Via the picture on the right, the carbohydrate loading will increase insulin secretion, which will then decrease the insulin resistance. And also with the receptor activation, you'll get decreased muscle inflammation. So once again, a big emphasis is that ERAS controls isolated by itself doesn't show much difference, but it is a multimodal approach where the difference does occur. So these randomized control trials looked at patients who fasted, drank water, and drank a carbohydrate drink and its impact on the postoperative course. The official term that they used was that there was a correlation with decreased length of stay, but not a statistical significance. The major statistical significance was better hand grip strength, and that was for frailty assessment. Most meta-analyses stated that there was no difference in length of stay. There was one that showed decrease with major abdominal surgeries by about 1 day, and high carbohydrate loading, this was with complex carbs, showed decrease in length of stay by about 1 to 7 days. Overall, though, there was no summary or no consensus that there was a difference. And these were all done with complex carbs and patients without diabetes. So this official recommendation via ERAS protocol is a 2B recommendation, which is weak with moderate quality evidence. So what do we give at our institution? On the pamphlet, it'll tell the patients that day 6 prior to surgery, you should start drinking the Ensure Immunonutrition Shake, which is seen on the right of the slide, 3 times a day for 5 days. And then once you get to day of surgery, then you will drink the Ensure pre-surgery drink as a clear carbohydrate drink the morning of surgery. That's what we offer here. Other institutions have used Gatorade, apple juice, accelerated, which I didn't even bother looking that one up. Seemed kind of interesting though. And then one of the other questions I had was, what about patients with secure airways, and how do we manage their nutrition with that? And there's actually no studies or official stances on this, which I was pretty impressed with. So what I had to do was actually take this protocol from UT Health Houston on what they did. And the biggest emphasis was, as long as the patient had a post-pyloric tube feed, no matter what, you can continue their tube feeds up until they're about to be transported for surgery. Then you can turn the tube feeds off and then suction whatever contents are left over via that tube. If the post-pyloric tube feeding is not there and it's just in the stomach and they're undergoing what's considered a higher risk surgery, such as a trach, posterior cervical spine, face and neck surgery, etc., then you can consider holding the tube feeds after midnight and then resuming once the surgery is done. But I thought it was interesting because at our institution, we just say hold tube feeds 8 hours prior to surgery, no matter what. And so I think this is a practice that we can change here, is to continue tube feeds with patients who have secure airways and post-pyloric tube feeds, and instruct the nursing staff to keep the patient fed and then to make sure that the contents are suctioned out prior to coming down to surgery. So when the patient comes down for surgery and they're in the pre-op bay, they actually receive their own multimodal pain regimen. One thing that I wanted to emphasize was IV versus PO Tylenol. The cost is about $40 on a quick Google search versus a 1 gram PO tablet's about 60 cents. When given IV, there's been higher peak concentrations and quicker time to peak concentrations for the Tylenol, but there's really no study saying that it is superior to PO Tylenol. Also, IV Tylenol has a side effect of hypotension when it's given. And so with that being said, the official stance was if a patient has a functioning GI tract and can tolerate PO intake, there's no clear indication for IV Tylenol over oral, with the exception being if the surgery is longer than 5 hours and a redose is appropriate. With that being said, if there are patients who are aspiration risks or have difficulty with PO intake, you can consider IV at that point. And then NSAIDs. Here's a brief med school reminder about the arachidonic acid pathway and the cyclooxygenase enzymes. As we all know, that these NSAIDs range from non-selective to selective. Now, what's one of the big side effects we get concerned about with NSAIDs? Anyone shout it out? What's up? Bleeding, yeah. And with a lot of the colorectal surgeries, there's anastomosis involved, and so we get concerned about anastomosis bleeding. Now, what I thought was interesting was there was really no difference based on selectivity of the NSAIDs. It was specifically more medication-based. So with bleeding, diclofenac was associated with the highest risk of leak. And then ketorolac and selective NSAIDs weren't associated with anastomotic leak in one meta-analysis versus another meta-analysis showed the risk was only with selective NSAIDs. So the literature out there is kind of up in the air about it. Overall, at this institution, it's currently avoided for those reasons. And I do believe that there needs to be a couple more studies released on what exactly we can give in that regard. With kidney risk, there's no need to withhold if kidney function is normal if you're only basing it off that criteria. And then also, this doesn't cover all ERAS guidelines throughout all subspecialties. So just keep in mind that it'll be different for bariatric, it'll be different for ortho, it'll be different for thoracic. So when our patients are in pre-op, the surgical staff will actually type in ERAS on their order set. And so you'll see that they'll have a clear liquid diet that starts at midnight. They do have an order to encourage incineraspirometry, and that they'll have a 1 gram PO Tylenol ordered for them along with gabapentin 300 milligrams. All right, quiz time again. This one I think is the second hardest question. A little bit of a read too. I apologize about it. So what is the official 2023 stance colorectal ERAS protocol has on nasogastric tubes? All right, I'm impressed because I would have gotten that wrong if I didn't make this lecture. So that's correct. The official stance is there's really no impact on the routine use of nasogastric decompression on nausea, vomiting, time to return of bowel function, or length of stay. So it shouldn't be given routinely. With that being said, if you have a reason to do it, do it. All right, blood loss and fluid management. Red. Clever, I know. Next question. What percent of crystalloid stays intravascular? All right, good. That is correct. 20 to 30%. What about colloid? Good. 40 to 50 is correct. And so I always thought fluid management was interesting as the patient becomes MPO and clear liquid diet. They're essentially still having to go to the bathroom, still depleting their intravascular space. As fluid leaves the body, though, the blood vessels will start pulling fluid from the third space. And so you'll kind of hear a lot throughout residency, throughout work, as so patients like these, they'll hold on, and hold on, and then all of a sudden they'll crump. And the reason for that sudden crump after holding on so long is because the body is trying to maintain homeostasis via pulling through that third space until it's out. So how many of us have heard these things? Patient was hypotensive, so I gave a fluid bolus. Calculate 421 multiplied by 8 hours. That's your starting fluid deficit for the surgery. And then urine output was low, so I gave fluid. Although these are indicators for hypovolemia, they're not diagnostic as a variable in and of itself. So what is the goal of goal-directed therapy? And I was actually shocked that there was really no consensus throughout studies on what the official goal was. Some of it said normal stroke volume variation. Others said maintaining MAP greater than 65. And then others would talk about the effects of hypotension and had different definitions for it, such as just MAP in 65 in general, MAP less than 65 for X amount of time, or how far below a MAP of 65 occurred during the case. So I came up with my own definition that it's not too much, not too little, but just right. I remember doing a case with Dr. Kilkelly where there was a lot of blood loss going on, and we got the ABG. And I remember Dr. Kilkelly looking at the ABG, and he just said, "We have achieved euvolemia." And so every time I think of fluid management now, I just hear Dr. Kilkelly's voice echoing in my head of, "Have you achieved euvolemia yet?" It's very haunting sometimes. Luckily, he's not in this room right now. So there were some goals articles did mention, though. Some that I didn't mention earlier: normal cardiac index, normal SVR, and then normal plethysmography, which is the pulse ox variation that you would see on your monitor. Just keep in mind that the official goal that you should keep in mind is to maximize tissue oxygen delivery without overloading the patient by optimizing your hemodynamics. So here's a couple other methods. So to the left, there's different modalities that you could use. And then to the right are official signs and symptoms that you can look out for as well. We know most of these: CVP, using echo to determine stroke volume, cardiac output, cardiac index, physical exams, vital signs, lactate on a ABG. So here's a Frank Starling curve where you can assess for fluid responsiveness and see if that works. So you can consider 500 cc bolus over 10 minutes to see if stroke volume increases. But with that being said, there's a risk of hypervolemia with that. Other places, they recommend 250 cc boluses to assess for fluid response, and then you can do it up to 2 times. Some other methods you can check: 30-degree Trendelenburg. You can consider a straight leg raise test, which I feel like when you're in a cardiac case and you're getting ready to wheel the patient back and the patient's hypotensive, and then you see their blood pressure just start bumping up really high, and you actually look at the foot of the bed and one of the nurses has one of the legs raised. It's like, wow, that really works. With that being said, you can't really do it intra-op all the time. And so this is more pre-op, post-op considerations you can use. Other fluid management methods that I found: one, there's the 4-2-1 rule that most of us know. One study suggested a maintenance volume strategy. Give 1 to 1.5 cc's per kilogram per hour for urine output and insensible losses. And if there's going to be large fluid shifts in the surgery, you can consider more. And then from there, do additional 250 cc boluses to assess the volume responsiveness. Yes, the bolus does work via real time. Many studies, though, have their own methods, but overall, there's not a specific superior fluid management strategy. With that being said, you should always keep in mind you should be using isotonic fluid unless otherwise indicated. And then the other big thing is, as we said earlier, patients with similar comorbidities undergoing similar surgeries were originally having huge variabilities in their outcomes. And so whatever method you choose to pick, just make sure that you have that as your standardized method so that you can avoid the variations in your patient outcomes. One specific standardized method that I saw for an institution was a 5 cc per kilogram bolus if the patient is hypotensive on induction, 2 cc per kilogram per hour maintenance if laparoscopic, and then 3 if open. And then that they said a urine output of 0.2 cc's per kilogram per hour is sufficient if other parameters suggest euvolemia. If you believe hypovolemia is the etiology of hypotension, you can consider 250 cc colloid boluses. And if patient remains hypotensive after that, then you need to reassess via other parameters of goal-directed fluid therapy, which this institution used esophageal Doppler to assess for the stroke volume variation and stroke volume. Torture Post Department, intra-op pain management.
Hey,
I'm not
Rob,
gonna.
sorry to interrupt,
Yeah.
Rob. Do you mind resharing your presentation on Teams?
Yes. Is that better from your end, Govin?
Yes.
Perfect. All right. So the official stance on pain management guidelines is multimodal opioid sparing pain management. We should already be using this in our practice with the current opioid epidemic going on. But some benefits of the opioid sparing techniques: return of bowel function and shorter hospital length of stay. This is actually one of the few variables in the ERAS guidelines where it shows an overall benefit of patient outcome. So quick review of the opioid sparing techniques: thoracic epidurals and regional blocks. blocks, as long as we have a dedicated acute pain team available, which I believe we do. And of course, these other multimodal regimens. Quiz time. What is Taylor Swift's favorite dessert? All right. Looks like we got a close one, but congratulations. Cheesecake is the correct answer. So early feeding, early mobilization, and PONB. For most of us, we won't be following these patients closely in their post-operative phase, but we need to remember that what we do does have an outcome on the patient. It can lead up to weeks after their surgery. Early and progressive mobilization can be impacted from RN via poor pain control and post-op nausea vomiting. Same with early diet in regards to PONB. So I just wanted to kind of quickly review. Most of us know this. So on the right side, there's the Apfel risk score for post-op nausea vomiting and then post-discharge nausea vomiting. To the bottom left of the slide, we have the risk factors for children. Via the American Society for Enhanced Recovery, we need to be risk stratifying all of our patients. So one thing I've noticed is we do a pretty good job if they have history of PONV of giving more than 2 prophylactic medications. But reminder that history of PONV is actually only one risk factor. So female, non-smoker, and under having opioids given as a medication is actually 3 risk factors right there. And then based on this society's guidelines, if they have those 3, then we need to be giving 3 to 4 agents. So remember that the biggest emphasis is that you're using different classes of medication, which I have listed here. Of note, there's also non-pharmacologic interventions you can implement. So hypovolemia, for those of us who have done OB, is a common cause of nausea. So you can give fluids, you can give them carbohydrates. You can consider other anticholinergics, antihistamines. And then a big reminder, if a patient does vomit, don't give what you've already given because it clearly hasn't worked. Make sure you're giving a different class of medication. So if we're able to keep these things under control, we can actually help our patients with early mobilization, which not really a solid definition. So any mobilization within 24 hours or 8 hours a day of walking around by post-op day 2, which I don't know many people that would actually want to do that. Prolonged immobility can affect the body in several ways. So atelectasis, DVTs, and skeletal muscle loss and weakness. There was actually a study done on Division I athletes staying immobile for 24 hours, and they actually lost 1% of their muscle mass over those 24 hours. One study showed patients who took 1,000 steps a day post-op day 1 had lower probability of prolonged hospital length of stay. Other trials reported that there was no difference, but the big emphasis is no studies have shown that there's harm associated with early mobilization. So in summary, reputation, get it? Ha. ERAS is a multidisciplinary approach centered around the patient to improve outcomes, decrease length of stay in the hospital, which in turn will decrease healthcare spending. Very few elements of ERAS will improve the outcome if it's isolated as a control. However, when you use a standardized multifaceted approach that includes several factors that aren't listed in this lecture, that's where the full benefit of ERAS comes in. And with the standardized approach, this will also decrease perioperative variability that our patients will undergo. So here are the guidelines that I mentioned in this lecture, along with the strength of evidence that is provided via the colorectal ERAS guidelines summarized for 2023. And then if you want to learn more, you can go to erassociety.org for free and look at these several different specialties that guidelines are on. Here's some references. And then just want to give a special thank you to Dr. Nelson and Dr. Montenegro for their help. And then also for Joe Kister, where are you? Not here. Joe Kister did actually fund the new official anesthesia conference laptop out of his own funding. So make sure you tell him thank you for making my life easier. Any questions?
Good job. I'm wondering, in field design, do you find anything online about just, I wonder sometimes if there's a higher incidence of case cancellations, delays when you give the patient the real instruction, because it's pretty, there's some complication, yeah, or it's complicated in a little bit, like the clear liquids versus not, coffee with creamer without. I think the more information you give them, sometimes it can be by no fault of their own. It just, they mess up the NPO guidelines. But did you find anything that said like, maybe that's why we haven't implemented it, or we're just, that there is indeed more cancellation when you try to delineate further with the guidelines?
I didn't find anything specifically that said rate of cancellation and what the patient may poorly define as a clear liquid. For those who didn't hear, Chris mentioned like coffee with cream, but in their packet, it does actually specifically state what is a clear liquid and what is appropriate. And so that comes down to part of the patient education portion. Yes, Dr. Cohen.
To be able to think about for a long time in more private practice settings. And if they're not protected, they could change.
That's it.
Sort of lack of education.
I think it would be nice, a lot of times we have patients in the pre-op area and we know if we're in charge of their case specifically, oh, it's going to be a little while to their surgery. And then I'd be nice, I think one of the fluids they use a lot with carbohydrate loading is just Gatorade.
Yep.
If they tell patients drinking Gatorade on your drive into the hospital, because that's about 2 hours for the procedure. I don't know if we could provide that to some of the patients. If we're like, I know is that, now that I'm attending, I guess, like this is not going to go in the next 2 hours. Let's give this patient a Gatorade. I think that kind of thing could help. Although, we have Gatorade just lying around.
We also have apple juice and cranberry juice lying around that can provide something for the patients. And this is in regards if other cases get delayed and the patients are left being hungry. Brian?
Are all the studies done on non-diabetics?
For the complex carbs, the ones that I presented were all non-diabetics. And that's only for the pre-op portion. So the other ones, I didn't read anything about that specifically.
Anything about chewing gum?
Oh, I'm glad I read a little bit more than what my lecture gave.
It seems pretty effective. Like, I know recently I came across a question where you can, if patients chewing gum before surgery, it's fine to go. They're just not like, it doesn't prevent, it's not like a 2 hour wait or anything, which actually I think it's something a lot of people may not know, but chewing gum is perfectly fine. But I'm talking also about just post-operatively, like there's some pretty good evidence it prevents post-operative ileus, it increases like our short duration of return of bowel function. It's like the cheapest medication in the world.
Yeah, so Dr. Brenner had a question about gum, and colorectal guidelines actually encourage the use of gum post-operatively specifically. They had no stance on gum pre-operatively, but they were trying to look behind the physiologic mechanism of why it works, but it does show that it does encourage a little earlier return to bowel function. But it's are they masticating and therefore the body thinks I'm about to receive food and starts moving? They're not quite sure why, but it did show a little bit of benefit with that. Anyone else? All right, well, if no one else, we'll get back to our cases.